Good morning, everyone. Welcome to the first CGR after the summer vacation. Life begins as a fetus, and today also we will be talking in this first CGR after vacation. We will be talking about the fetus only. So, Department of Maternal and Reproductive Health will be presenting CGR on fetal lung anomalies, antenatal detection, and postnatal outcome. So, there is 3 to 5% risk of congenital malformations. Lung malformations are the rare malformations with an estimated incidence of 0.3 to 0.5%. In 5 to 10% of cases, there is an associated anomaly. Antenatal diagnosis is important so that prenatal intervention can be done at a correct stage and also to plan for the postnatal management. So, respiratory system originates from the ventral wall of primitive foregut as a diverticulum. This elongates caudally to form the primitive trachea and bronchi. Further morphogenesis and differentiation of the bronchial buds leads to the development of the tracheobronchial tree. So, whenever there is aberrant lung morphogenesis at various stages, it can lead to the lung malformations. So, lung malformations occurs due to insult at various levels. When it occurs at a higher level, it leads to congenital high airway obstruction. When there is, because of this obstruction, there is entrapment of the lung fluid, which is not able to drain out. So there is collection of the fluid in the lungs, leading to the hyperinflated lungs. Bronchogenic cyst occurs because of the anomalous budding of the tracheobronchial tree with subsequent failure to recanalization. And so these are usually centrally located within the chest. Then there can be congenital lobar emphysema, in which there is overinflation of the affected parenchyma, primarily due to the obstruction at the level of the bronchioles. So the most common anomaly is the congenital pulmonary airway malformation, where there is disorganized development at the level of the bronchioles, leading to the multicystic masses, which replace the normal lung. And it derives its blood supply from the pulmonary circulation. The second most common anomaly is the bronchopulmonary sequestration, where there is this disorganized mass of tissue which is supplied by the aberrant systemic aberrant artery from the systemic circulation. Then there can be hybrid lesion, in which the lesion has the supply from both the pulmonary and the systemic circulation. So this is the spectrum of the lung malformation. Of this, congenital high airway obstruction syndrome has a very poor prognosis and is universally lethal. However, in all other malformations, if they are diagnosed antenatally at the correct time and managed properly, can have a very good outcome. So how do we diagnose them? So for that, the normal ultrasound, we need to do the ultrasound. And in the normal ultrasound, the lung fields are seen symmetrically with homogeneous echogenicity. And there is no evidence of pleural effusion or cystic or solid masses. So this is the transverse view of the thorax, where we can see that the lungs are symmetrical lung fields are seen on both the sides with homogeneous echogenicity with no mass or cyst. The same can also be seen in the longitudinal view. However, if there is an echogenic mass, or if there are multiple cystic lesions, or the combination of both, then the lung abnormality is diagnosed. So, as we have discussed, that congenital high airway obstruction syndrome is universally lethal. And here we can see that the lungs are so hyperinflated in this picture, and the diaphragm is everted down. And also there is a compression on the major vessel. So there is the development of this hydrops also. So we can see the collection of fluid. So, and then this is the autopsy picture, in which we can see that the lungs are so hyperinflated that even the rib markings can be seen over the lungs. So once a lung lesion is diagnosed, we need to see for the size of the mass, the location, its blood supply. Detailed anomaly scan should be done, and prenatal invasive testing is offered if there are associated malformations to rule out chromosomal abnormalities. Then we need to see for the secondary signs, which may occur due to the compression by the mass effect. So there can be mediastinal shift leading to the shifting of the heart to the opposite side. Also, there can, because of the mass effect, then can be because of this pressure on the inferior vena cava and by the direct compression on the heart, there can be the development of the hydrops. And then by the compression on the esophagus, there is impaired amniotic fluid swallowing, and this leads to polyhydramnios. So all these signs needs to be looked upon. So the size of the thoracic mass is the most important predictor of the perinatal outcome, along with the development of the hydrops. And this size of the mass is calculated in comparison with the fetal head. So basically the ratio is calculated because fetus will keep on growing throughout the gestation. So the metric which is used is the CPAM volume ratio to calculate the relative size of the mass throughout the gestation. This measures the three-dimensional size of the lesion relative to the fetal head circumference. So this calculation is based on the transverse and the sagittal views on the 2D ultrasound. Like here we see that this is the longitudinal section and this is the transverse section. And we have calculated the three-dimensional measurements. And then we have taken the head circumference, and all these values are then put in this formula. And then this is how CVR is calculated. So the higher is the CVR, poorer is the prognosis. So the clinical spectrum of these malformations is variable. So on one hand, there can be spontaneous disappearance, while on the other hand, they can be rapidly growing masses resulting in hydrops and stillbirth. And usually there is increase in size from 20 to 28 weeks of gestation when these lesions require close follow-up. So the small non-hydropic lung lesions can be followed with the expectant management just with the serial ultrasound. However, the larger lesions with or without associated hydrops need intervention in the form of medical therapy, thoracocentesis, thoracoamniotic shunt, or many other investigational therapies are now being done, like laser ablation of the feeding vessels. So, and many times it happens that the patient presents late after 34 weeks, or if the lesion does not respond to these interventional therapies. At that time, there may be a requirement of this ex utero intrapartum therapy. So this is, for this, a large multidisciplinary team has to be there. And the basic aim is to establish the fetal airway under placental circulation. So it converts a possible catastrophic emergency into a controlled planned procedure, because these lung masses cause airway compression, leading to difficult intubation. So the intubation is done while the baby is still on the placental circulation. Postnatal management depends on the size of the mass and the symptoms. If the mass is large and baby presents with severe respiratory distress, then immediate neonatal surgery may be required. Now, this was about the intrinsic lung masses. Fetal pleural effusion is also a rare entity occurring in around 1 in 10,000 pregnancies, occurs because of the disruption along the drainage pathway of the pleural fluid. And in this transverse view of the thorax, we can see that both the lungs are surrounded by the fluid, which is the fetal pleural effusion. So if the effusions are small and the secondary causes are ruled out, then it can be just followed up with serial ultrasound. However, if it is severe, then we need to do the intervention in the form of thoracocentesis as well as the placement of thoracoamniotic shunt. So now we will discuss few representative cases which were managed in our department, in which all of them had variable presentations and were managed with different forms of therapies. So for that, I would like to invite Dr. Shekha to present the cases.
Good morning, everyone. So our first case is 25-year-old second gravida with one live issue with previous cesarean delivery, present in our department with ultrasound suggestive of lung lesion in fetus. Aneuploidy screening was done and it was low risk. At 20-week one day, we did the ultrasound and found a hyperechogenic mass of volume 5.48 centimeter cube, occupying the left lower lobe of the lung. There was no mediastinal shift present. On putting colors, the feeding vessel, as you can see in the video, was coming from the aorta, just similar to the schematic diagram represented by the map. And lungs are supplied by pulmonaries. So when there is a mass getting a blood supply from the systemic circulation, the diagnosis of bronchopulmonary sequestration is made. Since there was no mediastinal shift and the mass was small, we tend to follow up serially by the ultrasound. At 25 weeks, the mass grows in size from 5 to 15, but in the follow-up scan, it further decreases in size. And after 29 week onward, we could not appreciate the mass in the further ultrasound. Like you can see, this is the ultrasound done at 33 weeks, 6 days, and you can see almost normal looking lung. There is no lesion identified in the ultrasound. This is the course that mass has followed. From 5 centimeter, it grows to 15 centimeter, and then it decreases. And from 33 week onward, we did not see any mass. The patient delivered at 39 week, a baby of 3.3 kg with good Apgar score. There was no respiratory distress at birth. Postnatal chest X-ray revealed no abnormality. However, CCT thorax has shown a consolidation with anomalous arterial supply from descending aorta. So our antenatal diagnosis of bronchopulmonary sequestration of intralobar variety was confirmed postnatally. Baby is 4-month-old now, doing well, and is in follow-up in pediatric surgery department. Bronchopulmonary sequestrations are the non-functioning mass of lesion that lack normal communication with the bronchial tree. It accounts for 0.1 to 6.5% of the total congenital lung lesion. Most of the cases, around 75%, regresses antenatally, but there is no reliable criteria to determine which lesion will grow and leads to hydrops versus those that will stabilize or regress. Therefore, serial ultrasound following is required in all cases. And also the postnatal imaging is required in all cases, including the cases that regressed or appear to resolve in utero. There are 2 types. Intralobar, most common type. As you can see, the mass is in intralobar variety, the mass is within the lung parenchyma and it shares the same pleura. In extralobar variety, the mass is outside the lung parenchyma and it has its own pleura. Usually, the extralobar variety has a relatively bad prognosis than intralobar variety, and it is also associated with the anomalies of other systems. So small BPS without mediastinal shift and hydrops are followed up with ultrasound. And postnatal evaluation is done by CECT. Large lesion, on the other hand, can lead to compression of fetal lung and heart, causing hypoplasia of fetal lung and resulting in hydrops. And here comes the role of fetal therapy. The fetal therapy in bronchopulmonary sequestration is done only when it is associated with hydrops or hydrothorax. And this is done in the form of interstitial laser occlusion of systemic feeding vessel, which is a very new technique, and putting a thoracoamniotic shunt. The literature review of interstitial laser coagulation, the case report shows that it is having a promising role, but we had not yet tried this in our center. Now we'll look on to the role of medical therapy in congenital in our next case. So our next case is 26-year-old, 6th gravida with 5 spontaneous losses, present at our department at 23 weeks with ultrasound suggestive of left lung lesion. Aneuploidy screening was done outside, it was low risk. On ultrasound in our department, we found a hyperechogenic mass of volume 13.9 centimeter cube in the right lung. As you can see, this is the transverse view of the fetal thorax, and this is the mass of a large mass present in the right lung. There were also multiple echogenic cysts seen within the mass. The heart was pushed to the other side, and there was no hydrops. On putting colors, we found that it was receiving its blood supply from the pulmonaries. As you can see in the ultrasound video, the mass is receiving its blood supply. And you can also see that there are cystic area present in the mass. There are macro and micro cysts present. Therefore, the diagnosis of congenital pulmonary airway malformation of mixed variety type 2 was made. The CPAM volume ratio was calculated to be 1.7. So it was a high risk congenital pulmonary airway malformation. As explained by ma'am, the CPAM volume ratio can easily be calculated. We just have to go to the perinatology.com. The software is free for all. We just have to put the all the parameters in this, and the software will calculate the CVR. And from this, we do the serial monitoring of the patient. So as the CVR was more than 1.6, therefore, and mediastinal shift was present, therefore the option of medical therapy was discussed with patient. Patient received prenatal course of dexamethasone therapy in the form of injection dexamethasone 6 milligram 12 hourly for 4 doses at 25 weeks, and follow-up scan was done. On follow-up scan, we found that the mass has significantly decreased from a CVR of 1.7 to a CVR of 0.08. As you can see here, the mass is has become very small and it is hardly visible. Patient went in a spontaneous labor at 38 weeks. The delivery was done by cesarean section in view of fetal distress. She delivered a 2.6 kg baby with a good Apgar score, and there was no respiratory distress at birth was present. Baby is 2 year now, doing fine. Baby is in follow-up in pediatric department at her own place. As you can see, the second birthday of the baby is celebrated, and no postnatal intervention had been required till now. So prenatally, the congenital pulmonary airway malformation is classified into 3 varieties. Macrocytic being the most common, in which there are multiple large cysts present within the lung parenchyma. Then comes microcystic, in which there is very small cyst present in the lung parenchyma, giving the appearance of mainly solid areas. And then there can be a mixed variety with both macro and microcyst, similar in our case. This is the Stocker's classification, which is mainly relevant postnatally. So low CPAM is mainly managed on the basis of low risk and high risk. The high risk CPAM, in which the CVR is more than 1.6, it is managed by the invasive therapy, in which the macrocytic is managed by the, in which there are 2 options, cyst drainage and shunt placement. The macros, which is mainly done for macrocytic CPAM, and low risk CPAM are managed serially by ultrasound. The literature review of medical therapy has shown a excellent resolution rate ranging from 68 to 86% and a survival rate ranging from 77 to 83% for the medical therapy in congenital pulmonary airway malformation. Therefore, medical management done at correct time has a very good prognosis. After this, we will see the role of fetal intervention in cases of lung anomalies. A 25-year-old primary gravida present at 31 weeks in our department with ultrasound showing pleural effusion in fetus. Her blood group was B positive. She was known case of hypothyroidism. Aneuploidy screening has not been done in this pregnancy. Ultrasound at our department revealed a left-sided pleural effusion. The cardiac evaluation was normal, but it was shifted to right side. The patient was counseled for the option of thoracosynthesis in view of a very massive pleural effusion. Ultrasound guided fetal thoracosynthesis was done. 46 ml of fluid was drained and sent for investigation. The investigations showed that it was 100% lymphocytes, suggesting the diagnosis of chylothorax. On day 2 of post-thoracosynthesis, we did the scan and see that the effusion had started to reaccumulate. On subsequent scanning, as you can see in the picture, the effusion had reaccumulated and increased. Therefore, the patient was planned for thoracoamniotic shunt procedure. By the time her chromosomal microarray report came out to be normal, patient underwent thoracoamniotic shunt placement at 32 weeks 6 days. This you can see is the Harrison shunt, which we put. This is the part of the shunt, trocar and cannula, Harrison shunt, loader, along with the guide wire. The procedure is done under local anesthesia to the mother. While the mother received local anesthesia, while the mother received local anesthesia, fetal anesthesia is given in the fetal thigh in the form of atracurium, and this keeps the fetal still during the procedure. This is the live video of the patient getting the shunt procedure. We enter the thoracic cavity by using the trocar and cannula. As we enter the thoracic cavity, because of the pressure, the fluid start to come out. You can see in the video, the fluid immediately decreases. And then at this point, we load the shunt and put it in the shunt and take the needle. It with the help of loader and guide wire. The shunt in such a way that the sink ring goes inside the thoracic cavity and the bladder comes out of the chest wall. We usually put the shunt, just below the scapula, so it will be difficult for the baby to displace it while it is in the mother. And you can see in the video the duct bladder of the shunt beautifully coming out from the fetal skin. So it will drain out the fluid from the thorax into the amniotic cavity. On after the shunt procedure, we follow a patient with the ultrasound. The shunt remained to be in place and the effusion was resolved. The patient had an emergency cesarean section delivery at 37 weeks. It's done in fetal distress. And as you can see, this is the first video of the baby getting delivered. After the delivery of the baby, the shunt is immediately clamped to prevent the pneumothorax. You can see this is the shunt clamped immediately. She delivered a baby of 2.3 kg with an APGAR score of 789, a good APGAR score. There was no respiratory distress at birth. Postnatal chest X-ray showed mild pleural effusion. The baby was managed medically in the NICU and discharged on day 10. Baby is 2 years, 4 months old now, doing fine. And same picture of celebrating the second birthday of the baby. So till now, we have seen a happy mother and a happy child. But the picture cannot always be rosy, as in our next case. A 31-year-old second gravida with one spontaneous abortion was presented at 19 weeks with ultrasound suggestive of bilateral pleural effusion in fetus. Aneuploidy screening was not done till yet. At ultrasound, we found a bilateral pleural effusion. There was no other structural malformation seen. The patient was counseled and ultrasound-guided thoraco and amniocentesis was offered. Patient underwent thoracocentesis and ultrasound guidance at 19 weeks 1 day. The result came out as the fetus came out as trisomy 21 and patient opted for termination of pregnancy. Isolated pleural effusion account for 1 in 10,000 of birth. It can be unilateral or bilateral. In 5 to 10% cases, it is associated with the genetic abnormality. It follows an unpredictable course already discussed by the ma'am. So in small effusion, we followed up by serial ultrasound monitoring, while moderate to large effusion required the fetal intervention in the form of thoracocentesis and shunt. The prognosis in cases of unilateral pleural effusion is very good, almost 90%. The literature review of thoracoamniotic shunt has shown a good survival rate ranging from 60% to 78%. Managing such complicated fetal cases is not a single person job. It required a multidisciplinary approach. So we are thankful to our neonatologist and pediatric surgery department for their enthusiastic support right from antenatal counseling to postnatal management of the babies. Now, to represent a similar case, I would like to invite Dr. Monisha on the stage.
Good morning. I'll be presenting our next case. 35-year-old, 7th gravida with previous 2 living issues with 4 abortions. She had a previous cesarean section and she is a known case of chronic hypertension, type 2 diabetes on insulin, and she had developed intrahepatic cholestasis in her current pregnancy. She was referred to our department at 27 weeks for fetal lung malformation. The ultrasound done in our department showed There was an echogenic mass. There was an echogenic mass that was seen in the left lung, which was measuring 4 into 3.4 centimeter with a volume of 23 centimeter cube. There was no mediastinal shift, there was no hydrops, and there was no other associated anomalies. The lung mass was measured by CPAM volume ratio, and it was calculated to be 1.06, which was a low risk CPAM. The mass is supplied. Next, we did a color Doppler, which showed that the mass was supplied by the pulmonary artery, and hence the diagnosis of congenital pulmonary airway malformation was made. The patient was subsequently followed since her CVR was a low risk. During the follow-up scan, the size of the mass remained unchanged, and there was no evidence of hydrops or mediastinal shift. However, on color Doppler imaging, it was seen that the mass also received its supply from the systemic artery, that's the aorta. Hence, the diagnosis was revised to hybrid lesion. However, its rarity in presentation led us to face a perplexing situation while trying to pinpoint the exact diagnosis. This is a simple illustration to understand a hybrid lesion. When the mass is supplied by the pulmonary artery, as well as it receives its supply from the systemic, that is from the aorta. On the follow-up scan, the size remained the same. There was no hydrops or the mediastinal shift. She delivered a baby of 3.3 kg at 38 weeks, but the baby had respiratory distress at birth, and hence the baby was immediately put on CPAP and was shifted to NICU. Postnatal evaluation was done. Chest X-ray was done on day 1, which showed there was a haziness, which was seen in the left lower lobe of the lung. The CECT thorax, which was done on day 3, showed there was a solid lesion which is present in the left lower lobe of the lung with multiple cystic changes, and it also received, this is the aorta, this is the lesion, so it also received supply from the aorta, and hence confirming our antenatal diagnosis of hybrid lesion. The baby underwent thoracotomy and left lower lobectomy with ligation and division of the aberrant systemic arterial supply from the descending aorta. Here you can see the intra picture where the mass is supplied by the aberrant artery. This is the mass that has been removed. The mass has been sent for histopathological examination, showed that was congenital pulmonary airway malformation type 2, which was consistent with our diagnosis. With team effort, the baby is now 11 months old, asymptomatic, thriving well, and is under regular follow-up in pediatric surgery department. Now, we will be presenting our 6-year experience in prenatal diagnosis and management of congenital lung anomalies. Congenital anomalies were accounting to 10.5%, and of all the total anomalies detected, 4% were involving the lung and the pleura, whereas the other system anomalies were seen in 96%. Now we'll be discussing about the demographic characteristics. Almost 75% of the women were in the age group of 26 to 35 years. Most of them were nulliparous. Most of the fetal diagnoses were made between 14 to 24 weeks. There was one case of pleural effusion, which was diagnosed in less than 14 weeks. However, more than 40% were diagnosed after 24 weeks, which is the legal age of termination of pregnancy. 73% were isolated lung lesions, and 27% of the lung lesions were associated with Other anomalies. Most common was the renal system. Most common was the renal system, followed by the cardiovascular system. Total lesions of the lung and pleura was 96, of which pleural effusion constituted 29%, whereas rest 71% is by the lung malformation. First, we'll be discussing about the pleural effusion. A total of 28 cases of pleural effusion. However, we excluded the cases that were associated with cardiac and other anomalies, and we are focusing solely on the cases where the pleural effusion occurred in isolation. So, isolated pleural effusion of total of 17 cases. 2 opted for medical termination of pregnancy. On further investigation, 13%, that is 2 cases, were detected to have chromosomal abnormality. Both had trisomy 21. There was mild pleural effusion in 46.6%, that is 7 cases. Hence, they were managed conservatively. About 40% had a severe pleural effusion, hence required prenatal intervention. The patient who had managed conservatively, 5 cases regressed, that is 33.3%, there was regression of pleural effusion, whereas another 2 had persistent pleural effusion, and hence postnatal intercostal drainage was done. All the 7 babies are doing well in their postnatal period. And the prenatal intervention in the form of thoracocentesis was done. 5 had reaccumulation and 1 regressed. Out of 5, 1 patient opted for termination and was not willing for further thoracocentesis or shunt procedure. 4 was willing for shunt procedure. And 5 babies are alive and healthy in a prenatal intervention. The overall survival rate was 80%. The systemic literature review of pleural effusion shows that there was a 590 isolated case which has shown that 85% of live birth rate. Our data has also a similar finding of 80% of live birth. Now coming to our lung malformations, that was total of 68 cases. The most common was the congenital pulmonary airway malformation, accounting for 69%, 10 cases of bronchopulmonary sequestration, and 12 cases of high congenital airway obstruction, 2 cases of congenital lobar emphysema, and 1 case of fibrillation, as we have already discussed. Among the CPAM, the most common variety was the macrocystic type that was seen in 48.9%. Of the 47 congenital pulmonary airway malformation, 2 opted for medical termination of pregnancy, where 2 were lost to follow-up. Antenatally, 41 patients were followed up, and they were divided into high-risk CPAM and low-risk CPAM based on the CGR. 92.6% were under low risk, and hence they were conservatively managed. But during the course of following, 73.6% remained within the low-risk CVR, whereas 23.5% progressed, that is the mass increased in size and hence progressed to high-risk CVR. The patients under low-risk CVR required only 2 required postnatal surgery, and rest were under postnatal follow-up, and all babies are surviving under the conservative management. In high-risk CVR, 53.8% did not opt for the intervention, and they had a very poor outcome comparing to that of the intervention group. Intervention group was in the form of steroid as well as shunt therapy. Only 1 required postnatal surgery, and all babies are alive and healthy in the postnatal group. The overall survival rate was 85.3%. Moving on to our next malformation is the bronchopulmonary sequestration. There were total among the 10 cases of bronchopulmonary sequestration, intralobar variety was a common, accounting for 70%. Of the 10 bronchopulmonary sequestration cases, 1 underwent MTP, 9 were antenatally followed, 3 required postnatal surgery, and all babies are alive and healthy. Postnatal follow-up are remaining 6 were under postnatal follow-up. All babies are doing well. The overall survival rate also very good in bronchopulmonary sequestration, accounting for 90%. Coming to the other lung malformation, in congenital high airway obstruction, which is a lethal malformation, hence all the patients terminated the pregnancy. Coming to the congenital lobar emphysema, there were 2 cases. One patient underwent MTP. Another required postnatal surgery, and the baby is doing well. As we have already discussed, there was one hybrid lesion which was operated, and the baby is doing well. Now summarizing 75% required conservative management, whereas 25% had prenatal intervention, and 18.8% required postnatal surgery. Coming to the review, the studies done worldwide shows that the 70 to 80% of CPAM was seen as was the most common lesion. As we see in our study also, the CPAM ratio is 69%. However, the postnatal surgery was required in 9 to 25%, as seen in the other studies. And we also had postnatal surgery rate of 18.8%. So this concludes the data. Thank you. I'll invite Sangeeta ma'am to conclude our talk. Thank you.
Thank you, Manisha. So now we see that fetal lung lesions are the rare entity, and the diagnosis can many times be challenging. And however, with proper diagnosis and proper antenatal management, we can do very well. And if we counsel the parents properly, so the malformation does not always mean that termination is the option, because these lesions might regress during the course of pregnancy, or with the antenatal therapy, these malformations respond very well. So postnatal follow-up is required in all the cases, because postnatal surgery also has a very good outcome. Interdisciplinary team approach results in very good outcome. And in our series, we had an overall survival of 68%. And when we exclude the patients which have terminated or who have lost to follow-up, then we have almost 90% of the babies who are doing alive and doing well. So now I thank all the patients, all our patients who had trust in us and came to us for their management. I thank the Department of Neonatology, Pediatric Surgery, Anesthesia, Radiodiagnosis, and all the colleagues from different departments, without whose support we would not have been able to manage these cases. Thank you so much.